Hi, folks. Welcome to the July LIVErNORTH um, talk. And I'd like to welcome uh, hepatobiliary surgeon Dr. Stuart Robinson, who's here tonight and going to give us a talk. Welcome, Stuart.
Thank you very much. So my name's Stuart Robinson. I'm a hepatobiliary surgeon here at the Freeman. Been a consultant now for 8 years, and I'm the lead for the neuroendocrine cancer MDT. And
Stuart, can we turn your volume up, or is it difficult?
probably, let me see if I can change my settings. Can you hear me properly at all? Or
Very quiet.
let me just stop.
We can hear you very loudly, so it's
Oh,
fine.
it's just here then.
Right, I'll share again.
You can hear it okay, Linda?
Yes, so can we. Yeah, it's
Okay, right. Well, we'll just
really,
leave it at that. I'll turn my volume up.
Okay, so I'll start again. So Stuart Robinson, I'm a HPB Surgeon at the Freeman Hospital, and been a consultant now for about 8 years, and I'm the lead for neuroendocrine tumor MDT. And about 2-3 years ago, NHSBT launched a pilot program for liver transplantation for neuroendocrine tumors. And I thought I'd come along to talk a little bit about what neuroendocrine tumors are and why you would want to think about liver transplantation for patients with neuroendocrine tumors. So neuroendocrine tumors arise all over the body. They're not don't arise in one anatomical location, so they can arise from typical locations would be small intestine, ileum, jejunum, appendix, lung, pancreas, very common. Small numbers from the rectum. Lung is pretty frequent, but they can come from anywhere. Thyroid gland, ovaries, cervix, adrenal glands, primary retroperitoneal tumors, very mixed bag of things. So they're a very diverse group of tumors, and they are diverse not only in the anatomical sites from which they arise, but also in the way that they behave. They can be relatively indolent, slowly progressive tumors to very, very aggressive carcinomas that without treatment can kill people pretty quickly. There is a misconception that neuroendocrine tumors are benign. They are not. They have all the same characteristics of any other cancer. They're locally invasive. They're able to metastasize. They typically do it much more slowly than what most people think of as a conventional cancer, but they do it, and they do shorten people's lives. And neuroendocrine tumors can be broadly divided to either functional tumors or non-functional tumors. And what we mean by that is whether or not they secrete a hormone that causes a specific syndrome. And you get a wide variety of different syndromes. So how do we classify neuroendocrine tumors? There are various ways that we can do that. We classify them by their organ of origin. So pancreatic tumors, small bowel neuroendocrine tumors, etc. And then we classify them by tumor grade. So the tumors are graded on grades 1 to 3. And the way they're graded is by looking under the microscope and working out how many cells are dividing at any one time. So how many cells are undergoing mitosis, cell division. And grade 1 would be a tumor where between 1 to 3% of the cells are dividing at any one time. Grade 2 would be 3 to 20. Grade 2 would be 3 to 20, and grade 3 would be more than 20 cells at any one time dividing. And the grade 3 group in particular can be a very heterogeneous group. You can be just into grade 3, or you can have a tumor like a small cell neuroendocrine carcinoma, which is really rapidly progressive. The majority of neuroendocrine tumors are grade 1 and grade 2, and that's the group that I'm going to talk about because that's what we see most commonly, and that is the group where liver transplantation is used. To give that some context, if you were looked at a conventional colorectal cancer, for example, and looked how many cells were dividing under the microscope at any one time, it would be something like 80, 90, and 100. So when we're talking about 2 and 100 cells dividing at any one time, they're much more slowly progressing. And then we can group the tumours based on their hormonal function. And again, you can get a very diverse range of hormone production. So small bowel neuroendocrine tumours, particularly that have metastasized to the liver, often produce serotonin. And that gives rise to this classic syndrome called carcinoid syndrome. And the old name for these tumours used to be carcinoid tumours. And that can cause a variety of problems. Often patients present with facial flushing, with palpitations, and they can also present with heart failure. So excess serotonin causes injury to the right-sided heart valves in particular, so the tricuspid valve and pulmonary valve. And so they can present with right heart failure, so which in itself can shorten patients' lives. If you look at pancreatic tumours, pancreatic neuroendocrine tumours, they can produce a whole wide variety of hormones. The majority actually of pancreatic neuroendocrine tumours are completely non-functioning. They don't produce any hormones at all. But the ones that do can really cause quite devastating symptoms. So for example, insulinomas are insulin-producing tumours, where patients can present with hyperglycemic seizures and end up often stuck in hospital for quite a period of time until you can manage their blood sugars. Or you can get gastrin-producing tumours, which produce, so gastrin increases gastric acid secretion in your stomach, and you get problems with refractory ulceration. You can get tumours that produce something called VIP, which causes excessive diarrhea and electrolyte disturbances, kidney failure because of the diarrhea. So some of these hormonal secretion by these tumours can really be quite problematic. It's an important way of classifying these tumours. The reason that I had a zebra on my index slide is that for the majority of these tumours, the way that they present is very vague. So if we take small bowel neuroendocrine tumours, which are one of the larger groups of tumours, they often present with vague abdominal discomfort, maybe some altered bowel habit, bit of diarrhea, bit of facial flushing. And that occurs in a woman in her, I don't know, late 50s. And you might say, well, the abdominal symptoms, well, they're caused by IBS. And the facial flushing, well, that's not that uncommon, is it, in a woman who's going through the menopause? So it's just menopause symptoms. And these tumours are often diagnosed late. And so the reason that Neuroendocrine Cancer Society has picked the zebra as its logo is that these things might sound like a horse, but they're not. They're a zebra.
Yeah.
So liver metastases probably occur in about 50% of all patients with neuroendocrine tumours. And there's an algorithm for how we can go about treating these. So first of all, you need to properly stage these patients. And we use, to stage them, we use a combination of conventional cross-sectional imaging, so CT scans, MRIs, but we also do functional imaging. So you give the patient a radioisotope that binds the somatostatin receptor, which is expressed on the tumor cell. And then you do imaging about 4 hours later, and you pick up the tracer bound to the tumor, and they help to localize metastatic disease. And what you really take away from this slide is that there are a whole variety of different ways that we might treat these patients. So if you've got a small number of liver metastases, then you can think about detection. Or you might think about alternative techniques such as radiofrequency ablation or microwave ablation. For those with more complex pattern of disease, you might still think about surgery, but major liver surgery. And in those with more diffuse disease, you tend to think about either liver-directed treatments or such as SIRT, which I'm sure people have talked about in the past, radioembolization, or something like peptide-based radionuclide therapy, which I'll talk about later, or systemic therapy such as everolimus. And in a small number of patients, liver transplant may well be an option. But before we talk about liver transplantation, I thought I should talk about some of the other treatments that we use typically in patients with neuroendocrine tumors. So the first thing that we would do for a patient with a metastatic neuroendocrine tumor is start them on something called a somatostatin analog. So somatostatin analogs are drugs that bind to the somatostatin receptor, which is expressed on the cell membrane of neuroendocrine tumor cells. And it's exploited a lot in the treatment and diagnosis of these tumors. The effect of that drug has various effects in the cell, but it can lead to increased cell death, reduces proliferation, and also importantly for patients with hormonally secreting tumors, it reduces hormone secretion, so it can symptomatically help as well. Historically, these drugs were just used to treat symptomatic patients. We didn't know what impact they had on survival. But about now, probably I think nearly 10 years ago, there's this study, which is a clarinet study, and a similar study using a different drug that randomized patients to receive either lanreotide or placebo for metastatic neuroendocrine tumors. And when you look at the survival curves, the median survival, progression-free survival, sorry, in the patients who received a placebo was about 18 months over, whereas for the patients receiving lanreotide every 4 weeks, median survival wasn't reached over the course of the study. So it was really quite a dramatic improvement in progression-free survival and overall survival. And these drugs are relatively easy to give. They're given as a subcutaneous injection once every 4 weeks. Patients have them on home care, so a nurse just goes to the house, or patients can actually give an injection themselves if they're working, for example, and don't want to sit around waiting for a nurse. And they're incredibly well tolerated. So we nearly always start patients on somatostatin analogs as a first-line treatment, whilst we then think about what other treatment options we might use. For a lot of patients, somatostatin analogs are the only treatment that we would use initially. Sorry, go back a slide. So how do we manage patients with neuroendocrine tumor liver metastases? This is a large series from the States. I think it was MD Anderson, I could be wrong. And they looked at various treatments for patients with neuroendocrine liver metastases. So liver resection, radiofrequency ablation, chemoembolization or radioembolization, I'll talk about later, and systemic therapy. And what you can see is that by far the best outcome is achieved with those patients who are able to undergo liver resection, closely followed by, at that time, radiofrequency ablation, although now we would use microwave ablation. So there's no doubt that if you can get the tumor out, the best thing to do is get it out. And on here, you can see an MRI of the patient. So this is the liver here. So you can see my mouse. And this is all tumor in the extended right lobe of the liver. The left segments 2 and 3 is free of tumor. And so this patient underwent an extended right hepatectomy and had all their tumor removed and did very, very well. So liver resection is, and even quite radical liver resection is very much an option for these patients, especially if they've got liver-only disease. And we do see very good outcomes. For patients who have progressed on somatostatin analogs, or who are not able to have somatostatin analogs for whatever reason, then an alternative treatment that we have available is something called PRRT, or peptide radionuclide receptor therapy. It's a long thing to say, lutetium in short. So what that is, again, it utilizes the somatostatin receptor that's expressed on the cell membrane. And this time it's again bound to the radioisotope, in this case, lutetium-177. And this is given intravenously. The molecule binds to the tumor cell, and then delivers the radiotherapy into the cell, where it damages the DNA and leads to cell death. And this treatment is given once every 8 weeks intravenous infusion for 4 cycles. And again, there was a randomized study a few years ago which randomized patients to 4 cycles every 8 weeks of Lutathera, plus continuing somatostatin analog every 4 weeks, versus high dose octreotide. And if we look at progression-free survival and overall survival, there was a advantage to giving lutetium. And actually, if we look up to 30 months, less than 50% of the patients have progressed at that point. This is important when we come to think about liver transplant later on, and I'll come to that when we talk about the criteria for liver transplant. Other options that we have are SIRT. I'm sure people at this meeting have talked lots before about SIRT. SIRT is radioembolization. So in this case, you're injecting little spheres labeled with yttrium-90 into the arterial supply of the liver, which get to the tumor and cause, again, death by DNA damage. SIRT doesn't exploit any specific receptor on the cell membrane or anything like that. It's just delivered straight to the hepatic artery. There are no randomized trials of SIRT for neuroendocrine tumors. So we just have case series, but we again see pretty respectable overall survival of about 60 months, median survival, overall survival after SIRT. But again, if you are able to treat patients with SIRT, 75% of patients will have not progressed at about 12 months post-treatment. So again, it's useful for stabilizing disease, if nothing else. We've also used SIRT successfully in patients with who've got really problematic hormonal secretion from tumor in the liver. And we found SIRT to be incredibly effective at reducing hormone secretion, improving symptoms. The problem that we have with SIRT at the moment is it is approved by NICE as a treatment, but it is not commissioned by the NHS. So we're not able to treat patients unless we get beads given freely either by the drug company or the patient's pay. So whilst we think it's a very good treatment, it's not currently commissioned. So moving to liver transplant. So back in 2022, the liver transplantation program for neuroendocrine tumours was launched in the UK. And to be considered for liver transplantation, patients have to meet certain criteria. So they're expected to have a grade 1 or grade 2 well-differentiated neuroendocrine tumour. And actually, at the moment, in the first half of the pilot, the grade 2 group is being limited to patients with a Ki-67 of less than 10%. So grade 2 normally extends to 20%. So it's patients with low grade 2 tumour. They have to have a primary tumour that's arisen within the GI tract, so a tumour that's drained by the portal venous system. So patients with lung carcinoid are not included, or patients with, for example, tumour in the thyroid or something like that. The primary tumour needs to have been resected prior to considering liver transplantation, or prior to going ahead with liver transplantation, sorry. And in terms of tumour burden, less than 50% of the total liver volume should be occupied by tumour. Now, if you compare that to something like HCC, that's much higher tumour burden than you would allow for something like HCC. And the patients need to have had disease stability for at least 6 months prior to transplantation. And that's where a lot of these other things like PRRT, somatostatin analogs, SIRT come in useful, because what it doesn't specify is how you have achieved disease stability. But you need to have had disease stability for 6 months. So a lot of these things like PRRT and SIRT can be incredibly useful to provide stability of disease whilst you work patients up for liver transplantation. And I'll talk about the pathway in a little bit more detail. So what is the patient pathway to consider liver transplantation for neuroendocrine tumours? First of all, you have to confirm that you have completely removed the primary tumour, or be able to demonstrate that that's technically achievable. And I think that's a really important thing because, for example, if you had a patient with a resectable tumor in the head of the pancreas, which would require a big operation in the form of a Whipple, so removing the head of the pancreas, duodenum, bile duct, gallbladder, and then reconstructing all that, and they had a liver packed full of metastases, I wouldn't want to go ahead and do a Whipple, which has no survival advantage, unless you can know you're going to be able to offer treatment in the form of a liver transplant for the liver disease. So you can still refer to the liver transplant MDT without having resected the primary, but you need to be able to demonstrate that you can resect the primary if that's the only thing getting in the way. Patients need to have been imaged in the form of a neuroendocrine protocol CT, chest, abdomen, and pelvis. They need to have had an MRI liver to properly stage their disease and make sure that their tumor burden is less than 50%. And they need to have had a gallium PET. Now, so gallium PET is, again, it's a molecule that binds to the somatostatin receptor and enables you to detect tumor. Gallium PET is something that's only available in certain centres. So it's available in London, I think Hull, Manchester, Edinburgh. At the moment, we have to refer our patients to London for a gallium PET. So it's not something that we use for all our patients. We do have alternatives such as tetrated scans, but they're not as sensitive as gallium PET. So it's something that we have to bear in mind when working patients up, that the cost of getting, for some patients, actually the cost of getting to London for a gallium PET is quite a lot of money. Once all that's done, patients are then discussed at a monthly National Liver Transplant MDT that's hosted by the Queen Elizabeth Hospital in Birmingham, has representatives from around the country. And patients are discussed there to ascertain, did they meet the criteria for liver transplantation from an oncological perspective? Make sure that you can't just, for example, do an operation and treat the disease with a liver resection, that they've had the disease stability, etc. Provided the National Liver Transplant MDT agrees that liver transplantation would be appropriate based on their disease, they're then referred for a conventional liver transplant assessment at their regional liver transplant unit. Provided there's no issues with liver transplant assessment, they then proceed with transplantation. And ideally, these patients should receive an organ within 6 months of listing. And so what are the outcome measures for this pilot program? So we're looking at overall survival at 3 months, 1 year, 5 years, and 10 years. Same for disease-free survival. What is the survival of those patients referred but not transplanted for whatever reason, either because they were out with criteria or because they weren't fit enough or what have you. And then a variety of quality of life metrics are being assessed as well for this patients undergoing transplantation. So why liver transplant? What's the evidence to support it? So a lot of the work around liver transplant for neuroendocrine tumours has been done by Vincenzo Mazzaferro in Italy, who published several series. So this series looks at 42 patients with liver-only metastasis from neuroendocrine tumours who were able to undergo liver transplantation versus 46 who were not. And if you look at both overall survival and time to disease progression, there are really quite dramatic differences between those who are able to undergo liver transplantation versus those who were not. So if you look at overall survival, at 5 years in the transplant group was 97%, 50% in the no transplant group, 88% at 10 years, and 22% in the non-transplant group, with a median survival of 62 months in those able to undergo transplantation, whereas the median survival was not reached in the, median survival 62 months in those unable to undergo transplantation, whereas it wasn't reached, weren't enough deaths in the patients who underwent liver transplantation. Similarly, if you look at time to progression, so within 5 years, those patients who were not able to have a transplant, 84% of them had disease progression, compared to only 13% in those who were able to have a liver transplant. Now, the criteria that were proposed in this study for liver transplantation labeled as Milan criteria, but very different to the Milan criteria for HCC. where the patients have, again, a confirmed histology of low-grade G1, grade 2, or neuroendocrine tumours, have a primary tumour drained by the portal venous system, so in the GI tract, and that primary has been removed with all extrahepatic disease in a separative curative resection prior to liver transplantation. Metastatic disease should be 50% of the total, less than 50% of the total liver volume, and they should have had stable disease or response to other treatments for at least 6 months prior to considering liver transplantation, and they should have had an age less than 60. And so you can see that the criteria that have been adopted by the UK pilot programme are exactly the same. There is some wiggle room in the UK programme for patients who meet all the other criteria but happen to be 61 years of age. The age is a relatively soft thing. This study, again from Milan, looked at patients who all met the Milan criteria for liver transplantation, and they compared two groups: those who were able to undergo a curative intent liver resection despite being within Milan criteria, but with extensive liver metastases, and those who underwent liver transplantation. It's not a randomized trial. The way they defined non-resectable disease, so patients who should undergo liver transplant, was the inability to completely remove all disease with negative margins, or patients who had insufficient liver volume post-liver resection. So in this group of patients with pretty advanced liver metastases, you can see that there is a clear advantage both in terms of liver transplantation, both in terms of overall survival and disease-free survival. And again, this is another series, this time from the States, which shows very similar things. So here, they looked at patients with advanced high burden of liver metastases who underwent either liver transplantation or liver resection. And again, a significant overall progression-free survival advantage to patients able to have liver transplantation as compared to surgery. Much closer graphs in terms of overall survival, but there was still an advantage in terms of transplantation as you get out towards 10 years post-treatment. This series was a little bit different to the Milan group. They included patients with, small number of patients with grade 3 disease who had poorer overall and progression-free survival, unsurprisingly, because they're far more aggressive tumours. I just thought I would go through a case. It's a made-up case, but nonetheless, it just highlights some of the intricacies of managing patients with neuroendocrine tumours. So this is a patient who presented, and they presented with lower limb swelling, diarrhea, abdominal pain, and facial flushing. So a very mixed bag of symptoms. And they underwent some imaging to investigate abdominal pain, and they found that they have a liver packed full of metastases. So all this here is tumour. There's another large tumour here. And the reason that they had diarrhea and limb swelling was because, well, the limb swelling was because of right heart failure from the carcinoid syndrome, as was the diarrhea. And the abdominal pain was from a small bowel neuroendocrine tumour that was causing venous congestion of the bowel and causing pain. So a biopsy from the liver revealed a grade 1 neuroendocrine tumour of small bowel origin. There was actually a tiny deposit of disease within the pelvis that was treated with external beam radiotherapy. And the patient went on to have an echocardiogram, and they had severe tricuspid regurgitation and moderate pulmonary regurgitation. So they were started on a somatostatin analog to try and control their carcinoid symptoms, particularly that of flushing. So this patient was turning bright red, flushing multiple times a day. Now, normally Lamreutide is given every 4 weeks. In this patient, we gave it every 3 weeks, which is unlicensed, but something we do quite often. And despite that, they still had uncontrolled carcinoid syndrome. It's worth noting that in someone with right heart failure, liver resection is out of the question, as would liver transplant be. So just as a little aside, how frequent is carcinoid syndrome at time of presentation? And in patients with small bowel neuroendocrine tumours, at least half of them will have carcinoid syndrome at the time of presentation. And the presence of carcinoid syndrome is associated with poor outcomes. So we'll go back to the patient. So we had a discussion about proceeding with embolizing the liver tumours to reduce serotonin secretion by the tumour, reduce the symptoms of carcinoid syndrome, ideally slow progression of a carcinoid heart disease. In the past, the way we used to embolize these tumours was by injecting basically glue into the little hepatic artery supplying the tumour. And so that just starves a tumour of blood. And it's very effective at reducing hormone secretion. But what can happen is that because of all the cell death that you get, you actually initially get a real surge of serotonin. And that can precipitate something called a carcinoid crisis, where you become incredibly unwell. And so our preference these days has been to use radioembolization, SIRT, because rather than blocking the blood supply to the tumor and causing immediate cell death, you're delivering radiotherapy to the tumor and you get much more gradual cell death. And you still see a very good improvement in symptoms. So this patient was treated with SIRT with resolution of their carcinoid symptom.
I'm making it so you can share your screen.
Fantastic.
And I think you're looking at my screen, aren't you?
Oh, looking at your screen. I'm sharing the wrong screen. Hang on. We'll try again. Is that working now? Can you see my slides?
See it, Zebra.
Yes, can we see it? Can everyone see liver transplant for neuroendocrine tumours? Yep. And a zebra.
Mm-hmm.
Yes, Stuart, we've got you. Thanks.
Okay.